We'll make a start. I just want to thank you all for joining us today for day 2 of our first virtual research ethics symposium. And I would like to start by acknowledging and thanking the Lekwungen people, including the Songhees and Esquimalt First Nation communities, for allowing my family to live, work, and play on their lands. As there will be attendees here from various areas in BC, Alberta, and Saskatchewan, I welcome you to take this time to acknowledge the territories where you live in the Zoom chat and the peoples whose historical relationships with the lands that continues to this day. Your moderator for this session is Sarah Flann. Sarah is the Research Ethics and Regulatory Specialist in the Fraser Health Department of Evaluation and Research Services. You can read her bio on the website for this event, but I wanted to highlight that I've worked with Sarah on harmonization of research ethics in particular in BC since 2016. And during this time, Sarah also completed her Master of Science with distinction in Psychology and Neuroscience of Mental Health program at King's College London with a focus on clinical and ethical considerations. I think I'm unmuted now, sorry. I'll continue on with that. So Sarah completed her Master of Science with distinction in Psychology and Neuroscience of Mental Health program at King's College London with a focus on clinical and ethical considerations in neuroimaging, machine learning, and the identification of individuals at clinical high risk for psychosis. As if she wasn't busy enough, she also developed the ethical patient-oriented research guidance for researchers in collaboration with the BC Support Unit, and more recently used her skills when working with us at Research Ethics BC and Clinical Trials BC to provide early guidance on informed consent procedures during the COVID-19 pandemic. So welcome, Sarah. I know you're very busy, and I appreciate the time you've taken to do this today. And I will now hand it over to you.
Thank you, Terry, for that lovely opening and welcome. And good morning, everybody. I'm so thrilled to be a part of this symposium and to be a part of this session. We have some lovely speakers today, and I just want to start by saying I'm joining today from Langley, and I am a settler on the traditional unceded lands of the Kwantlen, Katzie, Matsqui, and Semiahmoo First Nations. And I am very grateful for the opportunity to work, live, and raise my family on these unceded traditional territories. And before we dive into the topic today, I also just wanted to take a minute to send a word of thanks to everybody out here in the community. We're so fortunate in the research ethics community in BC that we've been able to work collaboratively to address the COVID-19 pandemic. And I know many of you have spent a lot of long hours on evenings and weekends trying to make the research machine work. So I just wanted to send a kudos to all of you, and especially like to thank Terry for her direction, and Paula and Aoife at Research Ethics BC, because you guys have just really helped bring everyone together. And I think all of us feel like our bi-weekly REBA sessions are a bit of a self-help group, and we get to talk to each other and see what's going on at other institutions. So just thank you so much for, bringing us all together so that this is a little bit more tolerable living situation. So we're going to start with a few housekeeping items. You're going to see on your screen some instructions. Each of our presentations will be followed by an opportunity to ask questions from the audience. So can you please keep your microphone muted unless you're prompted by either a moderator or the host to unmute. You can ask questions in the chat box as well. If you could just preface it with a question right before your question so that we can easily find it. We've got some folks behind the scenes kind of combing through the chat to see what questions are being raised. And you can also use the raise hand function. There's some instructions there that explain how to use it if you're on a PC or a mobile device. And I'm also just going to note that our sessions are being recorded. So if you want to see our sessions from yesterday or you can't make the session this afternoon, please, I encourage you after to view them because they've been pretty amazing so far. And I think that's all for housekeeping. We'll dive into our session now. So we're going to explore mental health and wellness in light of COVID-19. And pre-pandemic, 1 in 5 Canadians experienced a mental health or substance use disorder. Now with the pandemic, we've got some disruption to mental health services. We have widespread stress, anxiety, we have isolation, and we're seeing some exacerbation of mental health and substance use issues in people who have already been experiencing them, and we're seeing an emergence in new populations. So I think that this is a very, very important topic, and it permeates every aspect of what we're experiencing. Yesterday, the mental health and emotional well-being came up as well, and our sessions weren't specifically focused on that. And we're also seeing our opioid crisis intensify. So I'm so thankful that we've got our speakers to look at a few different cohorts and how the pandemic has impacted their mental health. So I'm very thrilled for our first speaker to enjoy us. We have Sarah Crowe from Fraser Health. She's one of our very own healthcare heroes. She is here to talk with us about the impact of COVID-19 on critical care registered nurses. Sarah's a critical care nurse practitioner at Surrey Memorial Hospital, and she's also an adjunct professor at UBC School of Nursing. Sarah, thank you for joining us today, and the screen is now yours.
Sorry, 1 second. Okay, can you hear me?
Yeah.
Excellent. Thank you so much for that introduction, and I just want to show my gratitude for being invited to speak today on behalf of critical care nurses. And while the study I'm going to share with you is focused on the staff at Surrey Memorial Hospital, I have been in contact with colleagues across the country, and I think the results of my study are actually a very good representation of the Canadian critical care nurses as a whole. So just to give you a little bit of background about how this study came to be, we're a 50-bed critical care unit at Surrey Hospital. We're split between an ICU and a high acuity unit. So the high acuity is an ICU step down. Early this year, we heard the rumblings of what was happening in China. And I think at the time it was this abstract idea of something going on. And I don't think initially we really thought we were going to be affected. And then we saw what happened in Italy, and the anxiety level was ramped up a bit. And all of a sudden the world became very small. And we started to hear a lot more about COVID-19 coming to Canada and what was that going to look like. And then very quickly, by mid-March, we were in the throes of it. And while we were preparing, I think there was still this undercurrent of disbelief that it was going to come to us. And the shock that it did and how quickly things evolved was incredible. So hearing staff, hearing the anxiety and the angst and the struggles on the units is what gave birth to this research study, really wanting the opportunity to hear and give the nurses who were in the thick of things a voice to be heard. So I put together a team very quickly. I do want to acknowledge in particular Dr. Fuchsia Howard from UBC School of Nursing and Dr. Brandy Vanderspank Wright from the University of Ottawa School of Nursing, who are my research mentors as I'm an early career investigator. And I also pulled together frontline nurses who were in the thick of things, Paula Gillis, Fiona McLeod, and Caroline Penner, and then also my research partner at Surrey Memorial Hospital, Dr. Greg Haljan. So we came together very quickly and put the study together, really wanting to understand the impact on our team. We heard rumblings, we heard the anxiety, and through it, there was also comments of, well, yeah, that person's anxious, but they're always anxious. And I really didn't want anyone to not be heard or to be dismissed because there was so much there. And as a nurse practitioner in the unit, I'm there Monday to Friday every week with different teams as they rotate through. And the feelings and the anxiety, you felt it the minute you walked into the unit. And I just really wanted to hear specifically from them what they were feeling and what was going on so that we can understand how we can support our teams better. So what we did is we designed a convergent mixed method study that used two different validated surveys. So one was the impact of event scale, which measures symptoms of post-traumatic stress disorder. and then the DAS-21, which measures symptoms of depression, anxiety, and stress. Interestingly enough, both these scales were actually used in some of the early studies that came out of China, sharing on their experiences of the pandemic when it first hit there. We also did semi-structured interviews. So participation was opened up to all the critical care nurses working in both the intensive care unit and also the high acuity unit. There's about 240 staff members between these two units. And amazingly enough, we had a 45% response rate within 4 weeks of launching this study. People had a lot to say and they wanted to be heard. It was absolutely incredible, the engagement that we got from staff. So we had 109 complete the surveys, and we had 15 who approached me to do one-on-one interviews. And I have to say that the 15 came forward very quickly and wanted to share, but there was also equally as many who came forward to say, I appreciate what you're doing and I'd love to talk to you, but I'm not in a good place and I just can't right now. So what we learned wasn't necessarily surprising, but I think the degree of what was going on was surprising to me. So our surveys showed that there's significant anxiety and stress. More than 50% of our participants were experiencing probable or significant symptoms of post-traumatic stress, at least at the time they completed the survey. It is only a snapshot in time, but at that moment there was a significant amount of post-traumatic stress. And then we also found that more than 50% are also exhibiting symptoms of depression, anxiety, and stress, with the higher overall levels being in anxiety and stress. The interviews really just shared with us that there was evidence of widespread psychological distress, really highlighted by anxiety, worry, fear. And it was interesting, there was a huge gamut from people who were anxious, but they were so proud of their teams and they really wanted to be part of history. So they actually had a positive spin on the pandemic and the opportunity to work within their teams. But at the far end of that spectrum, we also had staff who were so anxious that they were sharing that they were actually putting their personal affairs in order and were actually worried about surviving the pandemic. So we saw just a huge range of distress. When we broke down the themes, we really saw that the 4 sort of sub-themes that spoke to the sources of this distress really were the rapidly changing policy and information that were coming at staff, the overwhelming but yet unclear communication. They were trying to meet patient care needs in new ways while maintaining their own personal safety, and also trying to manage home and personal commitments with self and family. So just wanted to share that really, while we picked out sub-themes, they were all very interrelated, and then anxiety and fear kind of spoke throughout all of this. I really just wanted to share a few words from the participants just because they were so powerful. So when we looked at the rapid changing policy and information, we had one participant say, it was just super stressed about it all. I felt like everyone wanted to tell us stuff and they kept changing their minds. There was a million emails about what we should and shouldn't be doing. I'm so busy caring for my patient, I don't have time to read all that stuff you're sending. I'm sure it's super important, but I don't have time to read all that or go through my email and see what is the latest. It's super annoying that you finally have time to read something only to find out there's a new version or 3 or 4. I just want to know what I'm supposed to do and who I'm supposed to listen to. Another participant said there was too much information coming out, but it wasn't the right information that we needed or wanted. When we looked at the unclear, overwhelming communication, we had participants share things like, I would also like to see clear communication. There were so many different people trying to tell us what to do that it was frustrating. You never knew who had the actual truth and who didn't. It would be so nice to have a set day or time for new communication to come out, so you wouldn't have to worry that you were in caring for your patient with COVID and that there's some new email waiting with some important piece of information that you have no time to read or even know that it's there. That was actually a very common thread throughout some of our interviews, there was this fear that if I'm in the room and something new comes out, I'm not going to know. And what I thought was the right thing or the right piece of personal protective equipment has changed. And so there was this real sort of overwhelming frustration with not knowing what was right and accurate, and having too many people trying to give them information and guide practice. And while everyone had the best intention, I don't think they realized how it filtered down to our frontline staff. Trying to meet patient care needs in new ways while maintaining their personal safety. Personal protective equipment was definitely a source of anxiety for a lot of our staff. There was stories and rumors coming out of different parts of the country, things coming out of Italy, where people were running out of PPE. And I think as social media has definitely made the world a smaller place, that many of our staff have either personal contacts, family, friends who are working in these areas around the world, and just hearing the horror stories of what they were going through and then having to work in their own unit, there was a lot of anxiety and fear. Some of our participants shared comments that I've had moments of anxiousness when caring for patients because of the unknown. I've had to talk myself down, telling me I'm using my PPE. I've had many panic moments of, am I protected enough with the PPE I'm using? Another shared that one of the most frustrating things was donning and doffing our PPE. It changed how we organized our day by trying to do more cluster care. But there was some stress and anxiety around making sure everything was on correctly and taking it off correctly. And the half-mask respirators we used, while they made us feel very secure, they were really uncomfortable to wear, especially for long periods of time. And then managing home and personal commitments. Many shared stories of feeling isolated, feeling targeted, and just feeling very much like a leper, and that they were being isolated even more because of their job. Some of our participants shared, my first emotion was fear. I feared for my family. I was afraid of working on the front line would put my family at risk. I really didn't want to come to work. Another shared, I worried about getting sick from COVID or worse, spreading it to a loved one or to a vulnerable person and then feeling guilty about this. And another shared a experience that when she was walking her dog, we had people yelling at us for being too close, and we're just out walking our dog right now. And I think this really highlighted not only were our staff dealing with the fear and the burden of being sort of in the thick of things with the COVID patients, but there really was no downtime for them either. So they were constantly feeling the pressure or feeling the isolation even outside of work. We had some staff share with us that they'd actually started living apart from their families because of fear of bringing it home was so great. Being very, very isolated and not being able to do the things that they would normally do for stress relief. There was a lot of positives, and I don't want to paint a completely doom and gloom picture. That we did hear from many how they've actually built new coping mechanisms, they're healthier, they've taken up new hobbies, but they're definitely, this sense of isolation, fear, and burden was definitely there throughout. So we learned all of this, and we heard, and some of the team members, it was amazing to hear the stories and then to hear the simple thanks, that the appreciation to the research team just for taking the time to ask how they were feeling and how they were impacted, that it meant a lot to them. Some of the interviews were fairly short. They're 15 minutes, others were 40 minutes. But even in those 15 minutes, that sense of being heard and being valued as a member of the team who had something to contribute and something to say was evident. So what we've done now, aside from acknowledging the stress of our teams, is that we've begun to share the results with the senior leadership to help to improve processes and prepare for the second wave. I have to say, when I was preparing these slides a couple of weeks ago, we hadn't officially been designated the second wave, so I guess that's a little out of date now that we've been deemed to be second wave now. But we've seen an improvement. July and August, we had a slowdown, and I think the teams, we shared results early on, and they really took to heart the communication issues, the changing policy issues. And while we had a bit of a lull in the summer, there really was an effort put in place to make sure communication was streamlined and that the staff felt heard and supported. And then we also started working on resilience building and emotional support for our colleagues. So what we did is we brought in critical stress incident management team to help do some large group, I should say large group because we can't gather largely, but we had them available in the units to do debriefings. We also worked with a psychiatrist who has some training in resilience building, who did mini huddles on the unit within the teams, and then also set up Zoom meetings for 15 people to sign up so they could do it with their colleagues or their work family and have a safe place to have a conversation about how to build resilience, how to take care of one another, and that was really effective as well. In addition, we're looking at preparing, making sure that as we head into the second wave, that some of the gaps that we heard and fears are being addressed. So there's already a plan in place to keep staff up to date about the state of our PPE stores. That seemed to be a hot topic. We've already contacted some of our resource and resilience teams to make sure that if we see the same stress start to resurface, that we'll know what to mobilize quicker this time. And that was it for me. So thank you again for allowing me to share this. And I'm just so thankful to be able to give the frontline nurses a voice.
Thank you so much, Sarah. That was fantastic. I'm super impressed how quickly you were able to mobilize, get your research up and running, and then get your results together in a manner that the health authority and your unit could make some positive change. So I'm hoping that the changes continue to support you and your colleagues.
I have to say, from inception to the first draft of the manuscript was 4 months. It was incredible how much work we got done in a short period.
Yeah, on top of your regular duties, that's just commendable. I do have a question for you. When we get in studies wanting to work with frontline staff, I often feel a bit of a hesitation, like, oh no, you guys are so burdened, you're in the thick of things, you're on the front line. So it was really interesting, and I'm so glad to hear that your colleagues were happy to be able to share their voice and it was well received. I'm curious if there's a difference between the research being from within the department or if it were to come from an external researcher or somebody who's not embedded in your unit, if you think it would have been received as well.
That's a good question. I know that during the same time, BCNU, in partnership with UBC, had also launched a wider spread study that was looking at the impact. And I think for my study in particular, I am a familiar face, and I think there is a level of comfort with wanting to share the experience with me. I do think, though, that there was such an eagerness, even with staff I'm not familiar with. They really wanted an opportunity to share what it was like for them. That I think it would be well received. I think it depends on the format too, because I made the survey portion an online survey they could do anywhere, anytime. Mm-hmm. I think that really encouraged participation, and then the interviews as well was done at their convenience. So I think if done in the right way, I think there would be the same uptake.
Great, thank you. So we do have a question coming in here from Peter. It says, thank you for this presentation. The quotes are very compelling. It would be great to see demographic data to see that the respondents are representative of the population sampled. It would also be great to see details of the surveyed data. Did you detect moral distress? It seems that many of the causes of stress were systemic and not personal. How have you addressed systemic issues, and will you be repeating the survey during the second wave?
So when we first started asking the questions, my gut instinct was that we were going to hear about the mental health impact, but we started very broad, at least with these interviews, in just asking how it had impacted people. I really didn't want to steer them one way or another, so it really grew organically. And I agree that the issues did seem to be mostly systemic. There was a few personal pieces that were brought out, but the overall themes were very systemic. And so we've already shared that with the Critical Care Network for Fraser Health. And we're just in the process of revising a submitted manuscript. So hopefully will be published soon as well so that we can share more widely. And I'm happy, Peter, to share the data with you if you're interested, and it's also in the manuscript that hopefully will be accepted for publication soon. Repeating, I've been asked that a lot lately, actually. I haven't decided, but there is definitely an appetite to repeat it again to see if some of the changes have made an impact.
That'd be really interesting to see how the changes impact the second wave experience for your colleagues and yourself. So we have another question coming in from Kenna. She said, what a powerful presentation, such useful and impactful results. Will the results be spread through BC and Canada?
Yes, this is actually my third time presenting on this study. So the BC Research Roundtable that was run by the BC chapter of the Canadian Association of Critical Care Nurses, I presented that in September and they have a recording of it. But yes, my hope is to continue to share the results. The World Critical Care Congress is coming to Vancouver next year, and I know that there's a day planned on COVID, so I'm hoping to submit there to share the results as well, but definitely interested in sharing with whoever wants to hear.
Great, thank you. And we've got a question from Eugenie. She says, thanks so much. If you and your team were to repeat the survey or study in the second wave, what might you adjust?
Oh, that's an interesting question. I'm not entirely sure. Part of me, my first gut instinct would be to try and conduct it very similarly, just to be able to compare, to see what the impact has on the changes that we've been able to do. I have to be truthful, though, I don't have an answer for that. I would have to give that some thought.
Great. I'm just scrolling through to see if there's any hands raised in the crowd. Are there any other questions for Sarah? And if you think of something later, we are going to have open time at the end of all the sessions, so you can bring it up afterwards. So not seeing any hands raised, I think it's safe to move on to our next speaker. So thank you so much, Sarah. That was a fantastic presentation. Oh, hold on. I just saw one come in here. So here's a question from Dorothy. It says, we sometimes hear that research participants should be paid or compensated for their contribution to research. It seems like your participants were just happy to talk to you. Do you have any comments on that?
Yeah, they were really just wanting to share their experience. And I know that a lot of times participants are compensated. My study was completely unfunded. So I am very, very grateful that nobody wanted compensation because I didn't have any to give. I think done in the right way, though, and if the study is made easy for the participants, I think if the content or the topic is important to the participants, I think some are, and as my participants were, we're happy to do it without any compensation.
Yeah, and that's something, I don't know if we have any funding bodies in the crowd here that I just wanted to raise, is that being in a health authority, the vast majority of our clinician-led studies are unfunded. So we have folks who are doing the work and the research without funding. So that's just, I know sometimes when REB members and REBA are doing reviews, we have questions about, providing some sort of an honoraria for participants, but in a lot of instances, there's no funding to do that. So just something to keep in mind for the health authority context. It's a little bit different than when you've got some huge funds coming in from granting agencies. Let's see. Yeah, no more questions, I don't think, for this one. So thank you so much, Sarah. And there might be more questions towards the end, so I hope you can stick around. And now we're going to move into our next session from Dr. Megan Ames. She is assistant professor at the University of Victoria, and her research focuses on how psychosocial problems and health behaviors in adolescents impact cardiometabolic risk in young adulthood. And today, Dr. Ames is going to share research on adolescents' mental health during the pandemic. So this is another hot topic. I think often one of my children is a young adult, and I think often about the experience for them and what a difficult time it must be to be a young person just kind of getting a grasp on the world. So I'm very curious to hear what you have to say. So thank you for joining, and the screen is now yours, Megan.
Great, thank you, Sarah. Let me figure, still not so great at this stuff. Oh, here we go. Okay. So everyone can see my screen and the PowerPoint? Yeah, okay, good. Great. So thank you so much for inviting me to speak today. So this is actually the first time we're sharing these results. They're in a preprint right now and submitted for publication. Hopefully at the Journal of Adolescent Health. So I'll have in the second slide here, the third slide, sorry, the reference in case individuals are interested to hear more about these results. So this study, basically, it was funny, as soon as I got hired on, I was asked to join this study on youth experience of the pandemic with colleagues at York University in Toronto. And so we named it Teens at Home During COVID. So I'm going to be talking about today this study itself and our preliminary findings, as well as some ethical considerations, given that this is the BC Research Ethics Symposium, of doing online surveys with young people, as this is a new experience for me as a researcher as well. So there's increasing concern regarding youth mental health, given that youth were kind of sent home at March break and weren't able to rejoin school. A lot of their physical activity outlets were removed. Their were socially isolated. Youth also had anxiety regarding the pandemic, and there is increased risk for conflict in the home, given that everyone's at home and with high levels of stress. Systematic reviews on previous pandemics and disasters show increased risk for depression, post-traumatic stress disorder, substance use disorders, and other mental health concerns. And so we were really interested. There was a lot of research being done on parents of youth and children. And we really wanted to hear the voices of young people. So we had a number of measures that we included in our survey, but this presentation is going to be focused on just simply the rates of mental health problems and substance use, as this is the first data that we looked at from our study. So we recruited young people ages 12 to 18 through social media campaigns to complete an online survey mid-June to the end of July. And we purposely stopped data collection at the end of July so that we weren't getting inflated rates of, say, anxiety due to the return of school, since that was a pressing concern for a lot of young people at that time. We managed to recruit a large number of adolescents. So our final sample size after deleting duplicates was 809 with a mean age of about 15 and a half. Youth identified as female, half of youth female, male, and we also had a group of about 5% who identified as trans or non-binary individuals. So we're able to look at gender differences in the sample. We had 74% report that they were white, which is representative of the Canadian population. 95% were living with their parents, and 70% were within two-parent households. So in terms of results, so again, we had a lot of the research was collected in China from when the pandemic in previous months. We also had a lot of research on when individuals say youth, sometimes that means 18 to young adults. So we didn't have really great comparison data, but this was about, again, 3 to 4 months into the pandemic. So our rates of mental health were quite high. So 52%, so this is the Ontario Child Health Study Survey, 52% met clinical cutoff, so they're at high risk of being diagnosed with a depressive disorder. About 40% met clinical cutoff for anxiety. And we, like Sarah said, we had high rates of post-traumatic stress symptoms, and that was assessed through the Children's Revised Impact of Event Scale. We also had about 1 in 5 youth reporting oppositional defiance symptoms, as well as attention deficit and hyperactivity disorders. As expected, I have the gender differences just at the bottom there, but as expected, youth who identified as trans non-binary were typically higher than females, who are then higher than males. In terms of substance use, so this is substance use within the past 90 days. So we had about 40% of youth engaging in alcohol at some point within the past 90 days. So again, this was 3 to 4 months into the pandemic, so they would have been typically at home. 17% engaging in nicotine, and about 1 in 5 using cannabis. What was concerning was that about 1 in 5 youth reported engaging in substances at least once per week. And this is consistent with the literature. Our rates were a bit higher than kind of national levels, but what it seems to be happening is that the youth who were using are just using more. So we're interested to dive a bit deeper into that data. So our research was really showing that adolescents are experiencing a wide range of mental health concerns at this time. And it was interesting to see after 3 to 4 months, with kind of the comparison to the data that was collected right as the pandemic was hitting, just increases in mental health concerns. And so we really need to promote positive coping and accessibility supports for young people, which were at the time, unfortunately, really restricted due to social isolation and people kind of trying to hit the ground running in terms of how do we support youth at this time. And currently what we are doing a second data collection in November, and we've partnered with Big Brothers and Big Sisters of Canada to get a sense of how youth are doing now that school has returned. We are hoping that mental health has improved now that school has returned. And a part of this partnership is really to inform their efforts to take their mentorship program online. So how can they best support their vulnerable youth that they serve in an online format? And hopefully that research will really inform kind of best practices moving forward. Okay, so given that we're talking about research during a pandemic, typically sometimes we would have teens come into our lab, or we get permit, or we go into schools and we get typically permission from parents to engage in this type of research. So there are some ethical considerations when conducting this online survey and assessing for competency to give informed consent. So do youth know what they're engaging in when they're signing up for this study? And so there has been some research to show that if you don't kind of question a youth or a person's understanding of the purpose of the study and the risk and benefits, that they'll just kind of click yes and keep going with the survey without knowing what they're kind of getting themselves into. So Friedman conducted a survey where they had no questions, 3 conditions, no questions, 2 questions, and 7 questions, and showed that youth who didn't have any questions had a poor understanding of what survey they actually participated in afterwards. So we use recommendations from that body of research to specifically ask teens about 2 questions about the purpose of the study and 2 questions about the risks and the benefits of the study. And they were given 2 options, 2 times to get the correct answer. And they needed to get 4 out of the 4 questions in order to proceed with the study. And we did have, it comes at a cost that 168 of our youth failed the questions, didn't get all 4 correctly, and so were discontinued from the study. But we wanted to do that to ensure that youth had we were achieving some sort of informed consent. So this is just, it doesn't look great, sorry, the snapshot on the screen, but this is an example of a question that youth would be asked about the risks and benefits or risks involved in the study. And then the next page has, you know, if the youth had answered it incorrectly, it gives a prompt to answer again. Another ethical consideration when designing an online survey for young people, especially when we're asking about mental health and things like self-harm and suicidal ideation. We did have 2 items in our Ontario child health study asking about, you know, thoughts of killing themselves or hurting themselves. And so we wanted to obviously provide suicide prevention measures, given that we're not able to follow up with youth due to confidentiality, and as well as they could be completing it in the middle of the night somewhere without anyone there. Instead of, you know, if we have somebody come into the lab or research environment, we're able to follow up more thoroughly. So if a participant had endorsed or not answered questions related to suicidal ideation, they're given the option to either continue the study or stop and be taken to the end to enter. We had a draw for a $250 gift card. So they were still able to enter the draw. It wouldn't affect their chances there, but they were able to either continue or stop and go to the end and not answer the rest of the questions. And then those who, so we had 352 youth endorse or not answer those questions, so they were prompted, and only 12 decided to stop the survey afterwards. Everybody at the end of the survey, regardless of whether they stopped or not, were provided with a number of community-based resources, 24/7 resources that they could access if necessary. So that's the Teens at Home During COVID study. Again, we're very excited to continue this line of research with Big Brothers and Big Sisters of Canada. We're collecting data again in November and are hoping to follow up youth every 3 months for the remainder of the year. So we're going to provide hopefully pretty great data on how youth are doing over the course of the first year of the pandemic, and also how youth are accessing and benefiting from online mentorship, which can inform other online-based support services for our young people.
Thanks so much. That was fantastic. And I really appreciate the way you managed both the informed consent as well as following up if there's mental health concerns. So I'm seeing some questions pop in through the chat. So one of our questions is, did living with a 2, 1, or no parent home make a difference? And that's actually a question that I had thought about as well, because I think you said over 70% of your participants lived in a 2-parent household, and I don't know that that's in line with the average. I'm not sure about that. So I'm curious if you think your results might have been slightly different if there was, you know, having the stress of trying to go back and forth between homes during a pandemic, or living away from parents.
Right, and that's something we haven't looked at just yet. You're right, that's maybe a bit higher than national averages, but that's not something that we've analyzed the data for. But it could be, yeah, that if the youth were transferring back and forth, that could impact, you know, if you're kind of isolated from one parent due to being kind of sticking at one home, that could be impactful for sure, yeah.
Great, thank you. Okay, I'm starting to catch up here. We've got quite a few questions coming in. So here's a question from Paul. Megan, thanks for the great presentation and attention to both rigorous methodology and in particular the ethical considerations, which are the focus of our conference. Can you share any of your experience of working with the research ethics committees on the questions of competency for adolescents? Have you suggestions for research ethics boards that would help facilitate good research with adolescents while ensuring strong ethical basis?
Great question. So the study, as I joined in on the study was primarily done at York University. So I know my colleague, Dr. Stephanie Craig, was working closely with her ethics board there on how to best ensure the competency questions and was in talks with them about that Friedman study and how we can ensure that process. But I haven't been involved as of yet in terms of BC ethics and how to best, but I'm more than happy to engage in those discussions in the future.
Great. We've had quite a few folks ask if the slides can be made available after the session.
Yeah, that's perfectly fine. Yeah, and the slides I can also put in the chat, the link to the preprint if people are afterwards, so I'm not doing kind of two things at once, but the link to the preprint, which is our manuscript for publication that's currently under review.
Great, thanks. And we have another question from the group. What was the thought process for choosing the community groups such as Big Brothers?
So we had, for this data collection, we had reached out to Kids Help phone line and Big Brothers Big Sisters to advertise the summer cohort. And so we already had an existing relationship with Big Brothers and Big Sisters. And I think it just kind of went, we were thinking of doing a partnership grant for the SHRC Partnership Engage grant, and had great relationship with Big Brothers Big Sisters, so kind of took it further, the next steps. Yeah.
Great. So I don't see any more questions at the moment, but again, I'm just going to remind everyone that at the end of the sessions, we can ask more questions if they come to mind later on. So thank you so much, Megan. That was great.
Yeah.
And now we're going to move on to our next speaker. We have Dr. Ryan Rhodes. He is a professor, graduate program director, and the director of the Behavioral Medicine Laboratory at the University of Victoria. Dr. Rhodes' research focus is on the psychology of physical activity during the transitional periods over the lifespan. And your expertise is currently being applied to the impact of COVID-19 at different transitional life points. Thank you so much. And the screen is now yours, Ryan.
All right. Well, thank you very much. It's a pleasure to be here and chat about physical activity during these pandemic restrictions for the last 6 months or so. Let me just begin by, can everybody see this here? Okay, I just want to make sure that I can actually bring it into there, slide view. So just a quick overview of what I'm going to chat about today. I'll start with a little bit about physical activity and health. I know most people already know this literature, but it's always good to start to talk about how important this behavior is, particularly under current circumstances. And then a bit more about why we do what we do in terms of physical activity. So from the environment to the individual, and what happened during these restrictions, both in BC and across Canada. And then ultimately why it happened overall. From some of the research that we've done, and some final takeaways on this as we head into the winter particularly. So just very quickly, I'm the director of the Behavioral Medicine Lab over at the University of Victoria. It's a lab that's been around for about 20 years. It has a complement of about 15 to 20 researchers, and of all different, I would say all different stages of their training. Sometimes we even have people who are in high school doing some work with us in the lab, all the way up to postdoctoral trainees and full-time lab coordinators. And what we do most of the time is randomized controlled trials. But of course, I'm not going to talk about that today, because we don't, when we're looking at COVID-19, we haven't really had the rapid ability to start publishing those and analyzing those and picking up those data. But we are working on some of our interventions at this time. Instead, I'm going to talk about some survey research around pandemic restrictions and physical activity. Almost all of our work is with movement behaviors. So physical activity, sedentary behavior. We haven't done much with sleep, a little bit with eating behavior over the years. So as you can see here, my lab research has all kinds of different targeted populations. What I'm particularly interested in is people in transition. So, and that's why the COVID-19 restrictions were of interest to me as well. But I'm interested in that sort of train wreck of new parenthood and what happens to personal health behaviors. That became a personal interest of mine many years ago, but ultimately I grew into the interest of early family development, and then families as youth are getting older, and what happens to parents and kids at that point with physical activity and health behaviors, as well as transition into retirement, which is a very interesting time for personal health behaviors. You'll see here that I've got a picture of a dog here, and I've got dog owner research. Well, that's going to come into my presentation in a little bit. I always have some type of dog-related work with physical activity because it's so important to sort of system-level physical activity, as you'll see. And then what binds all this research together is that I'm in the area of exercise psychology. So I look at attitudes and sense of capability, personality traits, how people form habits for health behaviors or their lack thereof, how the environment interacts with the person in terms of health behavior. And what I'm probably most known for actually in my research is sort of the world famous intention behavior gap, which is made famous every year by New Year's resolutions that people never follow through with. So I think we can all relate a little bit to that. And so I study why that happens and how we can actually bridge that gap. So let's talk quickly about the benefits of physical activity. I don't want to spend too much time on this, but basically if you could wrap physical activity into some type of medication, it would be the most prescribed medication on the planet. It's associated with at least, physical inactivity, I should say, is associated with at least 25 chronic conditions. And these are our major chronic conditions that we face in the health and medical system. And of particular interest perhaps today, based on the theme, is how physical activity is related to psychological disorders and just general wellness. So its associations with depression and anxiety. It's an extremely powerful, regular physical activity is an extremely powerful antidepressant, for example. And so very important during tough times. Now, its breadth is not to be outdone by its depth, the magnitude of the differences of people who are regularly active. So what do we mean by regular physical activity? Well, I actually encourage you to go check this out because we just released new guidelines on physical activity for Canadians. And it includes actually a 24-hour for the first time type guideline where it's looking at sleep, physical activity, and sedentary behavior. But today what I'm talking about is 150 minutes a week of moderate to vigorous intensity physical activity. So you might see the word on the slides MVPA, and that's what that's getting at. That's really sort of the health, the optimal health benefit of physical activity is around that number. There's nothing magical about it. Of course, there's no problem if you're doing 140, and the curve just gradually gets better. So it's suggesting that every little bit is good, but that's sort of a good piece to shoot for at 150 minutes, and that's what we often do research around. And these are the results of people who meet that recommendation versus people who don't. You can look at the risk reduction around that. It's extremely impressive. You know, looking at type 2 diabetes in particular, 40% risk reduction is pretty staggering, but that's how important it is to a metabolic disorder like that. So of course, based on all those benefits, we all do physical activity, right? Well, no, we don't. And how much we do really depends on how we measure it. So these are data from a few years back now, but we actually have new data that says pretty much the same thing. The kind of bold bars there, that's self-report of who's meeting physical activity guidelines. And the shaded bars are when you put an accelerometer on people. So you can see that people think they're doing a lot more than they actually are. And by quite a bit. So on average, about 20% of the adult population are physically active. Less than 15% of child and youth population are physically active at their suggested level. So we're looking at a pretty serious public health concern given the magnitude of health and how little people are actually doing physical activity. When we think of physical activity, I think what comes to mind to most people would be planned activity. So that's kind of that top right quadrant there, exercise, things like that. But really, that's only one way that we get our physical activity. Other activities would be spontaneous activities. You can see this gentleman here running away from a dog. That wasn't planned that day, but that's sort of an alerted response. And so we have, often we're responding to cues and stimuli that will make us move. And then one of our big factors with physical activity in our day are more incidental activities where we hadn't really thought about the physical activity we were getting because we were thinking about the goals of other things that we're trying to achieve. Now, you can tell this is pre-pandemic because everybody's not socially distanced here in these figures, but ultimately the idea is that we have a lot of activity, for example, around transit, how we're walking to and from parking lots, walking to and from buses, moving around in the shops and things like that. And depending on how long we're doing that, that actually adds up into that health benefits of physical activity. So I'd ask you to think quickly just about your own physical activity as we move forward here and how these restrictions might be affecting it. Has it affected it at all? And if so, is it from less exercise? Is it from less of that sort of incidental activity? You're not in situations where ultimately things could happen to keep you active, or is it less opportunity for more spontaneous movement? And so we'll sort of come back to that here in the discussion in a little bit. Moving to why we're active. Wow, I have a whole course on this and we don't really cover the whole thing. So we're not going to cover it. This is the point of a slide like this is to actually show you how many factors are at work for why people are active in these various types of activities and why some people are not. And you can give you this idea of the scope around various aspects, all the way from genetic factors and evolutionary physiology as to why we move or why we like to sit, down to global factors and regional national policy. And when you think of COVID-19, I mean, it's affecting all of these really, but there's a huge possibility that it's affecting that regional and national policy sector, as we know, because we had all these restrictions that came in that then are going to trickle down to the individual. And sure enough, that's exactly what we found has happened. So as you can see here, this is from research around social and physical opportunities for physical activity. Almost 100% of physical activity related organizations have been affected over the last 7 months, 8 months. And so you can see that anything to do with sport, anything to do with the recreation sector, ultimately closed up shop or had quite major restrictions for a while. And these are kind of, as we all know, are going back and forth, coming in and then coming out again, depending on how we're doing. So most of these organizations are predicting that they're going to continue to have this struggle into the next year. Social distancing, of course, has dramatically altered activities even when they've been present. So you can see here that, you know, or even you probably know from anyone who's taking sports or exercise classes, we have definitely some type of an issue with that where it's even limited in how many people can get in. And so it's not surprising that reports from other countries are showing that physical activity is down and screen time is way up. So what about Canada? Well, that's the purpose of what I'm going to show you with a couple of cross-sectional data sets across the country here, as to get an idea of whether our findings are similar to other countries and other continents. And then I'll explore what the correlates were of any shifts around physical activity from these COVID-19 restrictions. I'm going to focus mainly on the MVPA. And again, it's not to demean any other type of physical activity, but this is the one associated most with health. You can see here a series of a bunch of citations. These are the citations of the work I'm about to show you. We've had about 7 or 8 publications on COVID-19 here in the last few months. And so I'm presenting sort of a snapshot of what all those presentations are. And so, as I mentioned, we have 2 cross-sectional studies that I'm going to present today. So nothing flashy from an research ethics perspective, you know, in comparison to, say, randomized controlled trials and various things like that we do in our lab. But ultimately, we recruited Canadian participants through a third-party marketing company. Now, what this company can do is it's large enough with its the number of people who are possible to recruit that we can actually resemble age, gender, region, and income and employment in the country. It isn't what you would call a representative sample because not everyone has the opportunity to respond, but it does end up representing Canadians, which is sort of the next best thing. We use self-reported physical activity, and there's a retrospective quality to what I'm about to show you that of course has some bias. So people remember perhaps the good old days before the pandemic, which really might not be correct, or they might minimize it. So we have to consider that when I'm showing you these data. And then the predictor variables I'm going to show you were validated from past research. This is just a quick snapshot of the data sets I'm going to show you. So there's one of parents responding on behalf of their children, and then the other is this adult demographics. And you can see that the reasonably equal proportion of males and females, sort of middle-aged adults reporting to this. You can see I've got the dog ownership bit here. So about 1/3 of the country owns dogs. And then we have some pretty decent neighborhood statistics, as you can see here. So we've got some decent variability with the sample. And the people meeting physical activity guidelines, it was lower, not surprisingly, and I'll show you in the very next slide, than what we normally would typically think of in our national samples. And so what we found is that about 46 minutes or so of weekly moderate to vigorous physical activity was missing, according to their representation of before COVID-19. So we're seeing the same typical drop as other countries. But I think this tells more of a story, this slide, because this is showing what people reported across meeting those guidelines. So you can see here that about 58% or so of the sample didn't really change their activity. So there were people who were inactive before and they just kept on being inactive. We had the ever actives, as you can see in that graph, and these are the people that just kept on being active, which is quite interesting. And then we have these three groups in the middle, which I think are they're the ones who have changed. They're the ones who were most interested in terms of the variance. And so we had this group that was active and just became inactive as a result of the restrictions, and they're a fair proportion of our sample. We had a group of adopters, a very small group. These are the group that weren't active and became active, and I'll explain in a moment who those people are. And then we had this group that we labeled breach and repair. So when the pandemic restrictions came in March, they collapsed in terms of their regular physical activity, but they found their way back over the month. So I think that's an interesting group to potentially learn from as we move forward. In terms of the child and youth sample, parents expressed that ultimately outdoor physical activity for their children was considerably down. And so that's what that top quadrant of the graph is showing. And that was all different ways that we were looking at it, from outdoor sport to walking and outdoor play, to anything outdoor. Indoor chores were up a bit, and indoor play was up a bit. Screen time was up considerably, as you would expect, and that's sort of replicating stuff of other countries. Sleep was about medium in terms of quality, and people were sleeping kids were sleeping a little bit more. But ultimately, time spent outdoors was taking a hit across the country. So why was this happening? Well, going back to the adult sample, and this is what this is showing, there's a lot of reasons why. So you can see here that there's a socio-ecological kind of bend to this whole thing, meaning that there's various factors that can explain what happened. So older adults appeared to be most effective in the transition, so they were the ones most likely to drop their physical activity. Those with higher education, higher income, and higher employment were also more likely to be active. Those who were engaging in social distancing actually were less likely to be active, and those who felt it was more of a threat were less likely to be active. We have individual correlates here of enjoyment, planning, those who had solid habits before, those who really identified with being an athletic person. They found a way to stay active. And then we had interesting social factors. So those who owned dogs stayed active from those who didn't. And those who had dependent children in the home were that adopters group. That was the only thing that could explain that small number of people who actually became more active, probably because they had kids and they needed to do something with them during the day. And then we had considerable home factors, such as the presence of home equipment, which was a very powerful effect, as well as home physical activity programming, which explained the breach and repair group. So the group that maybe was going to the gym or doing something with sports and then ultimately couldn't do that anymore, if they had home programming and took to that, they found a way back to regular physical activity. We had no effect on the built environment, but if you think about it, it was policies that changed, not necessarily the environment for most areas. So that kind of makes sense. In terms of child and youth, we found that boys were doing more than girls. Younger parents, children of younger parents were doing more, and those with a higher household income. So some similarities to the other adult group. Again, dog ownership predicted physical activity, parental physical activity, so active families, as well as parental support, which is not surprising. It's one of the most important factors. But here we did see a built environment effect. We saw density have an effect. So those who were living in smaller dwellings and had less areas and space actually suffered more from less physical activity. So what can we take from this before I stop? Well, I think the first thing to say is that not everyone changed, so it's important to look at why people change in profiles. And so that was perhaps one of the more interesting things of the work that we did. And we found that ultimately, when we broke it down a little further, we found that what has been lost the most is not exercise, but it was that incidental activities. So collectively, our research was showing that, people were stopping going to work, of course, and being at home. And so a lot of people were counting on that activity to meet those activity guidelines, and that was disappearing. And that's been across the world right now. Sitting was definitely up. So 94% of many of our samples said ultimately that they were sitting a lot more. And older adults have been most affected with their movement behaviors. And so we really do need to think about messaging for safe physical activity and older adult specific physical activities. And so there's been quite a few pieces of work that's been put out in the last 6 months or so around that I think can be very helpful. We found parents themselves increase their physical activity, particularly when they had kids in the home, because they need to do something, I think. It would be interesting to follow up on that and figure out what's going on with that sample. And then we have the usual suspects for anyone who does psychology of health behavior. Enjoyment is a big factor. When things got tough, the people who enjoyed it were the ones who ultimately found a way, those with good planning skills, those who identify with it, and those who had a habit structure in the first place. What this really, the important take home from this is that it wasn't about those benefits of physical activity. It was about many other factors that kept people active. So an educational or a psychoeducational campaign would likely not hold much value as we head into the winter. I mean, it's not a bad thing to start with the benefits of physical activity, but it's not the reason why people stopped. One of the other things we want to think about going forward is home physical activity options, as things are difficult right now. So I think some of you might know, but the actual secondhand like home physical activity market is so hot right now, it's unbelievable with home exercise equipment. And this is really in line with our findings, that those who found ways to do things at home were more successful. And we had some evidence of online workout programs and things like that. But I do want to caution around that, and that's why I put up this graph. We submitted this for publication only a few weeks ago, but we've been working on it for about 6 months. And these are the top 10 YouTube channels for exercise. And what we're showing is the view rate. And as you can see, people view for only a very short time. And if that's a representation of doing the exercises, it looks a lot like gyms look. So people get really excited for the first week and then drop off very, very quickly. So we still have some challenges to go if we're moving to an online world that kind of mimic the sort of the world famous, dropout phenomena when people go to gyms. In terms of families, and this is my last slide, outdoor activities have declined greatly. So I think we need to find a balance and continue to work hard to find a balance to promote outdoor activities for families while social distancing and safety messaging is there. And I think we're here in BC are doing a fairly good job of that. What we found is that Ontario in particular was the one suffering the most. And if you think back to Ontario, they had some issues around even people being in parks. Back in March and April, people remember getting tickets and things like that for being out in parks. So you can see that might be a real effect with families there, and that's why we saw that. But certainly special consideration for family activities in limited outdoor space could also be helpful. So helping people to problem solve around this, because we did find that had some effect with families. Some targeted messaging for girls could be very helpful, because we found that across the board, girls were doing less physical activity than boys. And so some targeted messaging could be helpful with that. And certainly the role of parents in helping to promote this physical activity for kids is going to be even more important than it was before. And it was extremely important. And just sort of a plug that we have recently, in conjunction with Participaction, which is the big social marketing firm for physical activity in the country, have put out a guide to healthy movement behaviors for families that I hopefully can put in the chat for you if you're interested. And ultimately it has a lot of different ideas and suggestions for moving that forward to help families be more active, and how various stakeholders can help that. So on that, I just want to say thank you very much for listening on this Thursday morning, and recognize that, of course, this is team science. So, I worked with a much larger team on all of these publications, and so I want to acknowledge all the people across the country who are involved in this research so far, and some of the ongoing research we're doing. Thank you very much.
Thank you, Ryan. It's very interesting, and I love that you included information on dogs. I know in our department there are a lot of puppies since the pandemic started, so we're seeing that's really helping a lot with the physical activity and mental health. I know most of us are working from home still, so it's nice to have my puppy home with me. I do have one question. I'm curious the difference between activity with the boys and girls. Yesterday in our sessions, we also touched upon the inequitable impact of the pandemic on women and girls. And I'm just curious if any of your data suggests why that might be, or if you're going to delve deeper into why we're seeing girls fall off faster than boys with the physical activity.
Well, it's a good question. And I don't have the full answer. I will say that with the adult research, we didn't find that there was a difference between men and women. And so there was a lot of the usual suspects were there, such as education and income, as you saw in the correlates, and age, but not anything to do with gender. So we didn't see it in our sample. We did see it with, of course, the boys versus girls. It's important to note that there is a difference there anyway. Mm-hmm. But it was reported that there was even more of a shift, as you're pointing out. So what we are going to look into what those factors are. And why we believe that's occurring. And look at maybe some specific targeted strategies around outdoor play and various play that girls might be more interested into. It might be more of a natural inclination for boys to be outdoor or be sent outdoors by their parents to go play. And so we do need to look at whether that's the case before we move forward. But these are the first indicators that, yeah, this seems to be happening, and it was already there was a difference. Mm-hmm. And so, as you pointed out, it seems to be even more affected by these restrictions, which is problematic.
Great. We look forward to hearing more on that. So I'm just going to go to the chat here. I see we've got some questions coming. So one question, are there any online certification programs related to the older adult demographic in BC?
So online certification for physical activity?
Rita, is it related to physical activity?
It may be solely physical activity, or it may be just the holistic lifestyle in general. Anything at all.
In terms of programming, there are quite a few different certificates around BC Recreation and Parks, Canadian Society for Exercise Physiology. There's quite a few certifications around promotion, and I'm sure I'm missing about 6 of them because there's so many. So the answer would be yes. I'm involved in a couple of studies around older adults that have really taken off and been very effective, and they've been around targeted online programming for older adults in exercise. So very specific exercises for older adults in a supportive environment. And so far, the study metrics have been absolutely outstanding. In fact, they've had much better attendance than they did in person. So there are some good pieces of news at times like this, because I think, the actual burden of going to a gym and things like that, or going to a place, is often itself a major barrier. We might be able to have had an improvement when it's good, high quality programming. And so hopefully we'll have some data from that in the next little while. I'm on a study with a couple of UBC researchers who are collecting this right now. And so far it looks very promising.
Great. I'm just scrolling here to see if we've got any raised hands. If you could give us one tiny thing each of us could do in our daily life to improve our physical activity as we're going into the winter months, like for someone like me who's not super active to begin with, what's one little thing I could maybe do to help improve my daily activity?
Well, that's a good one. It's a very important one because physical activity is quite individual. So what we do when we're promoting is we'll work with people to figure out what their life looks like and what their day looks like. But making it habitual can often be very important. And so the more systematic components to physical activity, I think, are helpful. What often some people love exercise, let's face it, but what many people don't like is exercise. So it becomes a struggle and it becomes cast off. And so one of the things to think about are more systematic ways in which you can include physical activity in your life that doesn't feel like it's just to do exercise. So, what we will often recommend is if you're walking to the stores and things like that, or if there are stores near to you, you could either park further away all the time and just start to create a little bit of a habit around a little bit more movement, or take that extra, 15 or 20 minutes if it is a walkable component. So often it's around walking. And the other thing that we focus on is the habituation of it. So trying to have it as a routine often is very useful, so that eventually it just becomes something that you do. And so the routine nature of it is something that we certainly suggest for people who, again, don't traditionally like exercise, which is totally fine. Exercise isn't for everyone, but physical activity is.
Yes, thank you. I saw Terry waving her hand. Terry, did you have a question?
It was just a thought about, and just wondered if you'd had any conversations with people about this, about those of us that have become kind of, well, you know, working from home, so feeling trapped in our own home for 8 hours, 9 hours, 10 hours a day due to the screens. If there's been any talk about, you know, employers having a responsibility for making sure that people that are working from home have those breaks, have that ability to get out and do something and are not maybe tied to the traditional 9 to 5 workday, because, you know, let's face it, with the virtual world, do we really need to work 9 to 5 all the time? Just thoughts around that.
So I'm right there with you. My life is like a 10-foot space around my computer and the kitchen. And so I think where we are in a very unique and interesting position in life, that we do have to actively think about how to break up our day, because we had breaks that were more natural before. Even if they were like we were saying in that presentation, the incidental activity of even just the idea of getting in your car or going to the bus or getting on your bike or whatever to get to work. We were relying on a lot of that to break up our day. And so I think it would be good to chat about this with employers. It would be it's a worthwhile thing to bring up, given how constant this kind of new normal is at the moment. And then even as an individual, if there's flexibility in your day, it is a good idea to start thinking about how can I break it up. I'm sure everyone here feels the same as me, but I mean, life on these screens can be very, you know, Zoom can take away your soul a bit at times. And so it is important to get up and move around. And I practice what I preach in this sense, because I do have that dog, and I do take the dog about twice a day on a walk around the block, even just to keep my mind off the computer for a moment and just get out and be active. And of course, not everyone can wants to have a dog, can afford to have a dog, or is it necessary? But the idea is still the same, that taking a little bit of time even to go for a quick walk, a little bit of movement, just to get your eyes off the screen. I think if your employer will allow it, it's a good habit to get into, even if it's sort of organized breaks. But excellent point.
Great. So I don't see any other hands raised, so maybe now is a good time to open up the floor if anyone has any outstanding questions for any of our speakers from this morning. Lingering questions out there for anybody? All right, I'm not seeing anything. Looking at the time, we've been very efficient this morning. I think we're all going to get some time back in our day. So if there's no further questions, I just want to thank our speakers all for being here with us this morning. It was very interesting and helpful information coming from all of you. And I'd also like to thank everybody who joined us this morning to participate. It's a great crowd, and it's so nice to see people from all over the place that, you know, as Terry mentioned initially, we would not be able to get together if this had been an in-person conference during normal times. So as a token of our gratitude, the BC AHSN will be making a donation on behalf of our speakers to the BC Food Banks. And I want to shout out our fantastic organizing committee. Thank you guys all for your work on this. All Things Research Ethics BC, this was a collaborative effort with volunteers from several of our partner organizations. And we're going to be sending out some feedback surveys at the end of the event to everybody who joined us today. So we encourage you to just let us know what you thought of the sessions, and if you have any feedback or comments for next time, because hopefully next time we can do this in person. And just to close, I just want to say to everybody, I hope you all are able to take some time for some self-care, take care of your mental and emotional health as we're starting to see Wave 2 start. Please do be kind to each other and stay healthy. And I look forward to seeing everybody hopefully this afternoon. And if not, see you later. Take care, guys.